you know, I don't usually introduce Grand Round speakers. I let, you know, the program directors and the people who, you know, kind of brought them here and to talk about it. But I had to use my executive privilege today for Chris Doty. And a lot of you know the story about Chris Doty, but some of you don't. So let me repeat that. So Chris Doty came to this program, and he was not initially granted an interview. So he applied here, and he was on our wait list. And I think like Elmer Fudd or somebody like that canceled their interview in the last moment. So we gave him a call, and at those days I was doing the interviewing with everyone else, and we gave him a call. And he came up in the last moment. He was the last person that I interviewed. And for those of you, you know, you go through the grueling process of being the interviewee, but the program directors are absolute heroes. It's devastating to go a whole season and, you know, your face is hurting because you're flying so much, and you know, how many sweaty hands can you shake? It's just a drag. So Chris Doty was my interviewee on the last day of interview season, the last interview. And he sat across from me on the desk, and I looked over to him, and I looked down, and I said, Doty. I said, what are you doing, Doty? How you doing? He goes, I'm good. I said, I'm tired. He said, I'm tired too. I said, you want to come to this program? He says, I think I like this program. I said, I don't know, man, you're from like Jefferson, like, you know, we're a little the county. He said, yeah, I think I like it. Well, the rest is history. We fell in love with each other, and I've been a Chris Doty fan ever since. And obviously, you know, he went on to be a chief and one of the greatest, and he is the greatest educator. But he's gotten every single educator award nationally that's offered. I mean, I think they invented some just to get his, you know, sorry butt up on the stage again. He is the epitome of what we're here for. We produce fantastic educators, and we put them out in the world, and they just make us look so good. So when you all come and see me on your administrative rotations, and I look down and I say, okay, Joe, you know, I'm sorry I didn't get to know you better. And you know, Foley and Holt, and you know, everybody made me make an appointment to sit down with you. And I'll say to them, and I always make people feel comfortable, I'll say, I may not be your Chris Doty, but I was Chris Doty's Chris Doty. You know, so I may not be your Derek Jeter, but you know, Derek Jeter loved Joe DiMaggio, and I was, you know, Joe DiMaggio for a while. So please put your hands together for our former program director and a superstar in emergency medicine, Chris Doty.
It is true. I do love Mike Lucchese. There's no question about that. So thank you. I appreciate that, Mike. Checks in the mail for that. All right. So we're going to do 2 lectures. It's super nice for me to be back here. You know, I love Brooklyn. I miss New York City every single day, but I needed to stay married, so off I went. But I will say, and I don't say this when I'm in Kentucky, but being the program director here was really the crown jewel in my career in New York, and is the thing that I am most proud of still, you know, in my educational career. And I've now spent 16 years, you know, doing emergency medicine education, and I learned by watching Mike and Stefan and the program directors and assistant program directors that came before me. So it's very exciting for me to be back here. Do you guys know how to use the Nearpod app? I saw Teresa give a lecture on this one time, so I'm pretty sure it's probably been deployed here already, but I love this thing. So you can just follow along here. We've logged in as a student. This will have all the slides. If you're actually logged into Nearpod, and Jimmy wrote the 5-digit code, JBALX, if you're logged into the Nearpod app on your phone, there's other resources, there's web links, there's PDFs, there's videos, there's about twice as many resources in the app. And I'll post it online so you guys can take a look at it. All right, so we're going to talk about difficult intubations, adjuncts for difficult intubations. So we're not going to talk about intubating much, a little bit, but in a lot of patients, the laryngoscope can be a murder weapon. Right? It's true. You can absolutely hurt people. So we're going to talk about one part of that is how do you ventilate patients different than the chronic respiratory failure stuff that we see, different than high-functioning, physiological, trauma patient who we need to control for their scans. So what about medically sick people that we need to do a different sort of approach on? So we'll do a case-based. 24-year-old grad student presents emergency distress, recently depressed, is unconscious with GCS. For about 2 months, people were talking about EMVs in Kentucky. I could not figure out what they were talking about. But they were talking about GCS. So finally, I figured this out. So GCS of 2, 5, and 3. You see vital signs there. There are some abnormal vital signs. I'm supposed to go forward. All right, so this is the ABG. Anybody have an idea what's going on with this patient?
Toxic ingestion.
It is a toxic ingestion. Anybody want to guess at what that might be? Salicylates, right? And one of the things that clues me in is when I get an ABG that I can't figure out, I begin to think about the salicylates. So this is our patient, obviously not her. That image is from the public domain. I just grabbed it off of Google. Here's her chest x-ray. We don't see a cause of anything there. So we send some stalling techniques, right? We send our results. That comes back with these results, not particularly helpful, as most stalling techniques are not. Right? We send a CBC and a Chem 7. We send a PT, PTT on thousands of patients. I don't think I've ever really changed my management, maybe like 1%, especially the coags. All right, so here's this stuff. So this is a profound metabolic acidosis. pH was very, very low. This is probably an acute aspirin overdose. Could be DKA. Could be a bad Colt's case. I'll talk about what a Colt's case is. Or it could be bad sepsis. Right? Sepsis, you would expect to see something on physical examination. Right? 95, I made this number up completely, but 95% of your sepsis is going to be in 3 places. It's going to be in the urine, it's going to be in the lungs, it's going to be on the skin. Okay? Don't miss those 3 infections, right? That's low-lying fruit. But Colt's case, which is my mnemonic for a anion gap metabolic acidosis, you probably learned mud piles. Mud piles is basically these things and then a bunch of causes of lactate. So when I was a resident, we had to memorize that stuff because we couldn't really measure lactate quickly. But you guys can get a lactate really, really quickly. And that, all the other stuff in mud piles is really lactate, lactate, lactate. Formaldehyde, that's lactate. Carbon monoxide gives you big lactate, right? So that's what happens, right? Ketones, uremia, lactate, toxic alcohol, and salicylates. It's my favorite cult right there. So, who's sitting up front? Oh, see now, it's tough to be you because you're old enough that I remember your name. No, could be you. Are you out yet?
No.
You're out?
No.
These
Oh,
are
ooh.
cheap.
All right. So what do you think? I recruited young master.
The last one's pretty
enticing. It is enticing. It is enticing.
I really don't want to intubate this patient. I think I want to start.
Okay.
So it's really hard to start.
All right, so we can start some bicarb. That may be one of the treatment. You guys can vote on your Nearpod app if you want to. We did have one person, the academic terrorist, voted.
So it was already too simple.
Renal replacement therapy. So,
Yeah, I want to do that.
so renal replacement therapy, what we would usually use is dialysis. There are a couple other things.
I definitely want that one.
All right, so a lot of people don't want to answer. Intubate is about 10%. We'll talk about that. That obviously is going to be the crux of what this case gets to because you've seen the title of the talk. All right, so I think both these answers are probably correct. You don't want to intubate these people with normal ventilator settings. You want to, I think you can intubate them sometimes during respiratory failure, and you can do it successfully. It's not easy, right? You can do it successfully, but you have to do it the right way. And if you don't, they'll be dead in 5 minutes. And that's an appropriate time course. They will be dead in about 5 minutes. Because their pH is 6.8, right? So if they get any more acidotic, off they go. So we're going to talk about settings, process intubation, what are the barriers, what are the concerns, and then what's keeping this girl alive? Her respiratory drive. Okay, good. So she's breathing off her PCO2. So what settings do you guys want to use? Low tidal volumes, high rate, okay. Anything else? Okay, pressure support. You guys want to use SIMV? Okay. If you're going to use SIMV, you have to tell me what volume you're going to give. If you use SIMV at a high rate, you're going to give her huge tidal volumes. You really want to give her tidal volumes of 10 times normal? Maybe. I think these are probably the answers. I think you can use assist control, you can use CMV, tidal volume 6 to 8 of predicted, and we'll talk about that. Rate 30 to 40. So that is what's different about this, right? You want to provide a rate at a normal tidal volume of 30 to 40. Now that means your minute ventilation is not going to be around 8 to 10 or where it would normally be. It means your ventilation is going to be huge compared to that, right? So FiO2 of 100% at least initially, and peak inspiratory flow of 60, that's going to deliver the breath pretty quick. Usually we're around 30, sometimes 60. All right, so there's a web page, there's a resource there. That resource is actually Scott Weingart, who you mentioned Weingart. I was just about to say something bad about Weingart, and the computer went out. He's everywhere. So I think Scott Weingart is super, super, super smart. I think he's also moderately crazy. And he does things that you can't really do, even in CCT, let alone in resusc UHB, which is probably not set up with the same stuff. I mean, the care is probably the same, but the resources are probably not the same. And then you get to a small community hospital in Paducah, Kentucky, and you certainly don't have those resources, right? So, but he has a great video on this particular topic. All right, so the core concept is try not to intubate these people if you can. You want to maintain minute volumes, right? Really high minute volumes, both during and certainly after. And it's after that we fail at, right? Sometimes it's the during, right? So this cannot be a prolonged intubation. This cannot be 3 attempts. Oh man, go get the CMAC. Oh, CMAC's in the other room. Okay, we'll bag him. That's not going to work, right? If you're going to bag him, you have to bag him at these super high rates. You want to maintain the ability to blow off acid. Peri-intubation arrest is secondary to acidemia. So when these people start to circle the drain, it's because they're getting acidotic. You need to blow off as much CO2 as you possibly can. And then if you have end-tidal CO2, if you can get that immediately on your intubation, that's helpful. Let's talk about case 2. 74-year-old nursing home resident sent from Ruby Manor. Is that place still open? Oh my God, it's over by Brookdale. Brookdale's a dirty word with me, but that used to be like a nursing home. It was like a killing field. And if you got anybody from Ruby Manor, they were guaranteed to be septic and pretty close to death. So patient's been in respiratory distress all day. Right? Now this happens, and we don't see a lot of nursing home patients here in East Flatbush. Occasionally we'll see profoundly septic people, but you're going to see this. And most of the EDs you go to, you're going to see nursing home patients, and they show up really, really sick. So it's been sick all day. Now it's 11 p.m. The MD who's doing rounds there decides, oh, well, they keep calling me about this patient. Let me just get them out, Send them to the emergency department. Patient's confused, lethargic, not following commands, pushes away the oxygen mask, right? Vital signs are here. This patient's pushing away oxygen. So what are you going to do? Intubate them, right? But you can't pre-oxygenate them, right? Because are you going to paralyze them to pre-oxygenate them? Or are you going to start the intubation with a pulse ox of 62%? It's a real life problem. Ketamine. All right. So the vitamin K, right, works for every single person. All right. So diagnosis is respiratory failure, and the problem is you have no ability to pre-oxygenate this person. So this is the chest X-ray. Pretty clear right middle lobe infiltrate. It's a lobar pneumonia, right? It's following pretty clear anatomic delineation of the right middle lobe. So it's probably pneumococcus. Stalling techniques. Right? Look, light count's only 7.8. Can't be septic, right? More stalling techniques. None of this particularly helps you. The bicarb is 18. Maybe that helps. All right, so respiratory failure with profound hypoxia. So lobar pneumonias do this. Aspiration pneumonia does this. Asthma does this. COPD does this. All right, lobar pneumonias actually knock you down much quicker because of two things. One, you have impaired gas exchange because of water in the alveoli, right? So you don't get good gas exchange there, and then it's tremendously inflamed, which means you have inflammatory markers which are going to raise blood flow. So you have a VQ mismatch that happens in both directions. Less gas exchange and more blood flow. So that's how these people get so sick. So what's your treatment? Well, we talked a little bit about this. Nasal cannula, 4 liters, wait for them to become apneic. RSI, starting with a pulse ox of 67. DSI, which most of you are probably familiar with. We're going to talk more about that. That'll be the crux of this case. Positive pressure, ventilation, and observe. Can you do that? Yeah, actually, you might be able to. I don't know if this person's a great person, but I think this idea that we can't put CPAP on people that are a little bit confused is probably misguided, right? And there's some literature out there to show it's pretty safe. Again, in terms of MICU. It's what they do in most EDs. This would be a MICU problem.
Dr. Doty?
Yes.
Would your BiPAP or your, would that be your, I guess, bridge to intubation?
So it might be. We're going to talk about that specifically as part of our delayed sequence intubation. So I think delayed sequence intubation is probably the right answer here. So you guys are familiar with delayed sequence intubation? Are you doing this on a regular basis, or you just listen to this on the podcast?
Attending dependent.
Attending dependent, okay. Well, if it's attending dependent, then you need to know about it. Because if you want to do it, you're going to need to drive the process. You still may say, Dr. Lucchese, I want to use this delayed sequence intubation, and he may say, well, I don't know anything about that. So if you know about it, you're more likely to have him follow along. Sometimes he's going to say, just bonk him on the head, throw a tube down his throat. Right? Because, Dr. Lucchese is sort of a caveman. No, he's not. He's a brilliant doctor, but occasionally you're going to have to drag your attendings kicking and screaming into the 19th century. Intubation, what are the settings, what's the process of intubation? These are the same core questions I want you to think about every single time. What are the barriers to a successful intubation here? What are your concerns? And what's keeping this patient alive? What's keeping this patient alive is not much. Right? They are actively trying to die. So RSI, this is a technique designed to be able to intubate people that have full stomachs. It's not an elective intubation. All right, elective intubations, you can do with RSI technique, but this is certainly not elective intubation. This needs to be done quickly. The idea is done RSI, and this was done wrong for most of my career. I didn't know better, and my attendings didn't correct me. You shouldn't really be bagging people with RSI. You should pre-oxygenate them and not bag them. Interposed bag ventilations will preferentially fill the stomach, unless you do some fancy stuff to try to prevent that. And then simultaneous administration of sedatives and paralytics, or inductions and muscle